So what I'm going to talk about is the microbiome and its connection to a particular cell group within the brain called the microglia. So the microglia, they control inflammation in the brain. Now, the way that I'm going to talk about this is in the context of a specific disease called motor neuron disease, which is one of the neurodegenerative disorders. But many of these theories, and this is just a theory, is applicable to Alzheimer's disease and many of the other neurodegenerative disorders. As Anton said, I'm a neurologist, and this is an area that I am on at the very sort of beginning of, about trying to understand the connection between the microbiome. Now, ALS, or MND, we use the terms interchangeably, was made sort of famous by the Ice Bucket Challenge, and so this is the problem. So on the left-hand side is the brain of a patient with motor neuron disease. On the right-hand side is a healthy brain. And the area that hopefully you can see is actually very small is the motor cortex. So it's a very, very focal area. So it's actually quite different to Alzheimer's disease and other diseases where there are much more global changes. This is a very focal area where the problem is. It's a fatal disorder. And we don't really have any effective treatments for it. Now, so when I told my daughter that I just received a grant that there was a potential connection between poop, which is her word for poop, and the brain, she was absolutely delighted about it. Yeah, and it's still a source of a huge amount of Mickey taking for my 7-year-old daughter. To me is this picture. I was also quite surprised to find out that the microbiota and the brain are similar weights, which is interesting. But moving on to motor neuron disease. Now, we all have our sort of mental picture of a stereotypical person with motor neuron disease. It's a terrible disorder. It's a rapidly progressive. It starts with a motor dysfunction in sort of one area, either arms or legs, or occasionally in the bulbar regions, and it spreads. And one of the unique things with motor neuron disease is that it spreads in a topographically specific way. What by that I mean is that if it involves the hand, then I know exactly where that area is in the brain. And so if it involves the leg, it's a similar thing, which is very different actually for neurodegenerative diseases, because when somebody gets lost or their behavior change, say with Alzheimer's disease or frontotemporal dementia, it's hard sometimes to pin that down. The other thing about motor neuron disease is that there isn't really a stereotypical patient with motor neuron disease. And one of the key things that I tell my patients when I see them is that talking about prognosis and what's going to happen in the future, you can leave to fortune tellers, but from a clinical point of view, we just simply don't know because there's a huge amount of variability. So what I'd like to do is just show you a video of Alan, who's one of my patients.
It took 3 days of tests to eliminate other conditions before Alan Wright was given a final diagnosis: motor neuron disease.
You know, it's a bit of a shock, obviously, but my wife and I are sort of pragmatic. You know, there's a few why me and a few tears. It's a very frustrating disease because of the lack of use of your arms. Simple tasks like shampooing your hair, shaving, become a bit of a from my point of view, it seems to be progressing fairly slowly-ish. My right arm is very weak and my left arm is getting weaker. So we're still able to enjoy life and go on holiday and get out and about. And so for as long as that continues, the better.
So yeah, I wanted Alan to sort of explain the problem there. In his case, it's his arms which are involved, and it sort of started in sort of one region. So he isn't confined to a wheelchair. It isn't the sort of stereotypical picture of someone like Stephen Hawkins, who's sort of profoundly affected. But we know that the disease spreads, and so we know that the legs can be involved. we know that the bulbar region can be involved, and obviously the diaphragm and sort of breathing. The problem is to do with the motor neurons. It's a sort of an obvious statement, but there are two of them. There's the lower motor neuron and there's the upper motor neuron. There was a debate in the 1870s about where the disease started, about whether it was the blue line or whether it was the green line. A chap called Charcot thought it was all to do with the upper motor neuron. Gowers, who's one of the or is the grandfather of sort of British neurology, thought it was all to do with the low motor neuron. I think that's partly in response to being told that it was all to do with the upper motor neuron. He just took the opposite approach. And to this day, we actually still don't know where the problem is, as in we don't know where the disease starts. What we do know is that we don't really have any effective treatment. We've got one treatment called Riluzole, prolongs things by a few weeks. What we know is we're actually very good at doing trials that don't work. So we've had over 100 negative trials, and every time you look at in the Lancet, there's another trial that hasn't worked. So I just want to quickly talk about why, and this we'll come back to the microbiome and the potential sort of the interaction. Okay, so this is us. Yeah, this is all of us. We all get a little bit better with our motor function when we're young. So obviously you start off as a baby, but as soon as you get to about 18 months-ish, you develop that ability to be able to sort of pick up things, and you develop your fine motor control. For my daughter and my dog, that was the start of an interesting relationship, because my daughter could suddenly do this, and the dog suddenly realized that he could get a whole load of food from my daughter. Now, our function generally is actually preserved. So we try to maintain our function until we get older. Yeah, and then we know that our function drops off. Now, the slightly shocking thing is that it drops off in everybody. Yeah, and the one thing that's guaranteed is that in the long run, yeah, we're all dead. And this is coming from an economist. Yeah. Okay, so what happens to our motor systems is actually very different. And so our motor system peaks early. And by early, 18, 19, 20, I mean, you don't need me to tell you this, you just look at the Olympics. It's pretty obvious everybody's young. And we're on our motor system's actually on a downward trajectory, actually ever after that period. But we actually maintain the function with something called neuroplasticity. So our brains respond, and they change and they adapt. And so this idea of the brain just being this sort of static thing which doesn't actually do much is we know is just wrong. Your brain is constantly adapting, and we can measure this now. So we can measure it with different types of brain scans. So if anybody juggles, there was a great paper which showed that if you learn how to juggle, then you can see changes in the brain in the right regions. So this is in the parietal lobe, so that's all to do with your visuospatial areas. You can see those areas increase. Now, when I say increase, they increase with the signal to do with the MR. What that actually means with the neurons is still an ongoing question. But the important thing is that also when you learn how to juggle, now nobody really maintains that skill. Yeah, it's the sort of thing you do in first year. Somebody learns how to juggle. By second year, you've got other things to do. Your brain then goes back to normal. Yeah. So what we know, and if you think about that over a lifetime, you can sort of see what potentially some of the changes. Now, in motor neuron disease, we know that your function drops off actually much quicker and much more rapidly. What we don't know is what happens to your motor system, whether that motor system changes occur months, years in advance. What we do know is as we learned from Alan's story, is that it starts off in a particular area and it spreads. We know there's an element to this which is developmental. So if you guys want to if you look at your hands, this is a great trick to win some money in a pub. If you ever need to do this, you can take photocopies of people's hands and you can separate them into boys and girls. Yeah, and the way you do that is to do with your ratio between your first finger and your ring finger. And that is determined, turns out, by the amount of testosterone that you had intrauterine. Yeah, so obviously boys have slightly more. So it turns out that increases your chance ever so slightly. Well, there's a susceptibility element that occurs in motor neuron disease, or it increases your chances a little bit. We know there's a susceptibility element to this. Everybody knows the stories about, well, actually, typically the people with motor neuron disease, they've just ran about 4 marathons, very high level sort of patients. It's very rare to get somebody who's, well, it isn't very rare, but it's unusual to get somebody who's been through lots of illnesses. And then they eventually get a diagnosis. Now, one of the great challenges is that we have this sort of pre-diagnostic phase where they have a symptom and they don't have a diagnosis. Now, by the time they get to having a diagnosis, is actually typically about 14 months from them actually developing their first problem. Yeah, and in a disease where a large number of people are dead at 18 months, you can understand why the trials are all negative. And in fact, your average time to enrollment in a trial is 17.4 months. It's not going to work. I mean, it's fairly obvious, I think. If you're going to, I mean, you need to close the door before the horse is like even vaguely got out. So the target, and I think this is one of the targets for lots of the neurodegenerative diseases, is to try and get things early. But I think with motor neuron disease, I think it's a good model for the other neurodegenerative disorders because it's so focal. Okay. So part of this is that I've set up this clinic at the National where we're trying to get people much earlier, and we're managing about 6 months after their symptom onset. So we have an advantage. Now, this means that we can test different hypotheses, and this is where the microbiome sort of comes in. So just being funded, and this is all theoretical, so I'm at the nice stage of being able to say, well, this is what I've been funded to do and talk about it, and I don't have to worry about the results because I don't have any. Yeah, if I'm invited back, then I'm going to have to start talking about results, which is when I'll be sweating more. Okay. So this is really to look at the connection between the microbiome and these inflammation cells in the brain. Now, this is what part of what my group does is that we look at the brain. So this is just a fancy, nice piece of artwork to look at the different wires. So we can look at the connections. We can look at the grey matter density. So with the juggling, we can look at the areas that increase or decrease. So there's all sorts of things that we can look at. Now, the microglia, these little inflammatory cells, they're central to pretty much all of neurodegeneration. So they're there. They're thought to be there to actually potentially mop up the abnormal protein that misfolds. Now, protein misfolding is something that's pretty common across the neurodegenerative diseases. So in motor neuron disease, the protein's called TDP-43. In Alzheimer's disease, there's a toss-up between whether it's tau or it's beta-amyloid. Different groups have got different ones, and there's an interaction. But ultimately, there's a protein that misfolds. And the microglia, these little inflammatory cells, potentially may actually be protective very, very early on in the disease. So potentially they're a really nice target, because if they're there and they are protective, then actually if we can help them along, then potentially we could actually try to delay whichever neurodegenerative disease from progressing a little bit. When we look at patients with motor neuron disease, and these are patients who are sort of well established, the key thing to spot, so just the red is bad basically. And when I showed you that brain initially, I showed you the motor cortex. And you can see that, not surprisingly, in areas in patients who have got a problem with an arm or a leg, it's in the area that's an arm or a leg is where the microglia are active. And a similar thing that people have problems swallowing, it's in the swallowing centres. What we don't know is how this progresses. And we know that this actually relates to atrophy as well. So this is where the areas, they're in the same areas that shrink. So thinking about that brain again at the beginning, they coexist. Oh, not well. They appear to coexist. We don't know the relationship between the two. The theory is that the microglia precede any atrophy. Okay, so can we target them? And this has been something that's always been an issue with pretty much all neurological diseases. We're left with this great hypothesis of saying, yeah, look, if we could only affect those cells, yeah, we could solve all of these issues, yeah. But trying to get past the blood-brain barrier, trying to recreate all of those sort of positive studies in mice is always a challenge, because obviously humans, we're complex beings, and our brain is in a unique position, as in it is hard to get things past the blood-brain barrier, and it's hard to deliver drugs. So trying to squeeze it into the CSF or something, it's all very, very invasive. So we were left with this problem. Now, many things in life, I've realized, are just pure chance, right? Now, one of my issues, the one thing that I have a thing about is I can't be late. And this leads, I've wasted so much of my life at airports getting to somewhere early, yeah, because I just don't like rushing at the end. So because of this, I tend to turn up to conferences and other places like amazingly early. So I was at a conference, nothing to do with the microbiome, nothing to do with neurological disorders. And it was the Wellcome Sanger Institute. So it's a massive building. I mean, it's like a huge area, yeah? And there's one other person there, right? And this is Ian. And Ian's from Cork, okay? So there's me doing my usual sort of very British, I'm not going to talk, and then there's one person over there, but I'm just going to get my coffee, I'm going to stand there and look at my phone. And I'd just spent time at NIH in the States, so I really had emphasized I really don't want to talk to anybody, yeah, because it was hard to get into a lift at NIH without somebody talking to you. Very uncomfortable feeling. So Ian, being from Cork, just strolls up to me and we start chatting. And obviously I'm feeling awkward. But then turns out Ian had a paper that he was talking about with sort of Paul O'Toole about the microbiome. Now, I must admit, I hadn't really, I mean, it had been on my radar, but it was in my radar of things that I was like, yeah, okay, I'll have a look at it at some point, but there's no mechanism there. I don't understand how it can have an effect. And if I don't understand the mechanism, then I don't see the connection. So I had this paper out, which showed that actually your microbiome actually correlates with your diet, but it also correlates with health in elderly sort of people. Now, I always give Ian a slightly hard time about the next figure, because I always have to remind myself before giving a talk about what this next figure means, because it isn't the most, or it isn't, I mean, to me at least, it isn't easy to sort of understand, yeah? It's completely clear, isn't it, yeah? No. So, okay, so what this is basically showing is, and it is an association, it's not causation, is that at the bottom, so as you're heading from left towards right, you look at frailty, and as you're heading the top, you have people in the community dwelling and people who are in a long stay facility. What they're essentially showing is that your health, and they've got sort of markers of sort of frailty, so blood pressure, mini mental scores, all sorts of different things, actually relates not only to your microbiome, but relates to where you actually live. And obviously where you live and your microbiome sort of go together a little bit. So Ian was telling me all about this, and I was like, okay, this is all very great, this is great, blah, blah, blah. And then in his talk, I tend to try and do things that there at the time. This paper had just been released actually in Nature Neuroscience, showing in mice that actually your microbiome control the function of these microglia. And it was one of those moments where you go, actually, you know what, there may be something in this, because the thing about the microbiome, even in MND patients, all the neurodegenerative diseases, is that it's something that you can target easily, potentially. Well, it's easier to get to than the brain, I guess. And one of the interesting things about this paper is that it shows that it's not just a matter of, it's not an issue just purely with developmental issues. So we know that if you have a mouse, you put it in a germ-free environment, yes, it has issues with its microglia. But what the paper went on and showed was that if you then restore the microbiome, the microglia get back to normal. So as Anton said, this is a constant sort of dynamic relationship, which is really, I mean, I think potentially it's really, really interesting. So this allows you to start thinking about, well, the microbiome and the microglial axis. So this is being very specific I'm after these inflammatory cells, because that's where I think the problem is. Anton's already covered this, that the potential mechanisms about how this occurs and how this interaction occurs is a challenge. There's been some interesting work with sort of short-chain fatty acids, but I mean, there's a lot of different sort of theories about how this works with the microglia. We know, looking at other neurodegenerative diseases, this is all in mouse models, is that if you have a mouse model that's programmed to overexpress one of those proteins, so in this Parkinson's model, it's a protein called alpha-synuclein, that if the mouse has the normal microbiome for that mouse, or in that environment, or in that lab, it's not something that's really controlled from my understanding. And once again, I don't work with mice, but from my understanding, is that it's not something that's given that much thought to, which is interesting. But when you wipe out, or when you have a germ-free model, that mouse does not develop the same sort of phenotype. So it doesn't develop Parkinson's model to the same extent, and the pathology, i.e. the amount of protein that it accumulates, is actually much reduced. And for a mouse model, mouse models, they're there to like overexpress proteins to a very high level. So actually the fact that you can alter that is actually very significant. Then what they did, and this is one of the things that I like about the microbiome, is that you have an interaction between the clinic and the microbiome. You have an interaction between the clinic and the mechanistic understanding. So what they did was they took a microbiome from a Parkinson's patient with aggressive disease, put it into the mouse, which once again, it's not something I've ever done myself, but from my understanding is you soak the pellets in poo water. It's a bit more of a stricter protocol than that, but essentially, that's it. The mice, they're not fussy mice, and it turns out that they will get an enhanced motor dysfunction. So i.e. they develop a more aggressive phenotype, which is really interesting because it moves this from being an association to this being sort of causation. There's obviously work from sort of liver patients in other diseases, speaking to one of the hepatologists who works on alcoholic liver disease, and it turns out that if you transplant the microbiome from an alcoholic liver disease patient into a mouse model, you don't lace the mouse with any gin or vodka or anything else, just the microbiome. It actually develops inflammatory changes in its liver. So this isn't a unique thing to just the brain. There's some interesting reports coming out now. Once again, a different disease, so Alzheimer's disease. This is a mouse model again, a different protein, but once again, the idea that the microbiome, and if you remove the microbiome, it affects the amount of protein that's produced, and therefore changes the phenotype. So it may be that, that's really, really interesting. But this is all in mice, and being a cynic about mice is that we're not mice. Yeah? So to me, we have to be able to do this in humans, which really comes down to what I'm sort of planning on doing. So the idea is to look at the relationship between the microbiome and these microglial cells in M&D patients. So we can look at these microglia, these little inflammatory cells in M&D patients. They're slightly, it's hard to do because it requires, well, actually no, it's easy to do because we can put them inside a scanner. It's hard to do because the scanner costs about £5,000 per shot per patient. Yeah. So the easy bit's the technical aspect. The hard bit is getting somebody to pay for it. So the idea for this is that there's going to be in sort of real-world ALS patients. So this all comes from the early diagnostic service. And this is, I think, an important part is that we get them early. So if you think back to Alan, so that would be when one arm was involved. Because ultimately, if I can predict or slow down his other arm being involved, then from Alan's perspective, that's a win. Yeah, I don't have to stop everything, but if I can delay that, then that's important. And we'll potentially, the idea is that we can influence the microglia, and that this will give us a new therapeutic target. Now, sort of written at the bottom, almost in a smaller font, yeah, was that we're going to do an FMT intervention. So we're going to transplant microbiome to M&D patients. Now, this has all sorts of issues because it's like, well, how? Yeah, what are we going to transplant? We don't know what's upregulated. We don't know what the microbiome is in M&D patients. But what we do know is we need to get it early, otherwise we know it's going to change for all the other reasons. So this bit, the bottom bit, is the high risk bit. The aim is not to target, we're not aiming to improve function. What we're aiming to do is we're just aiming to look at changes in those little microglia. So we're aiming for a change in the microglial activation. We're going to do this in 32 patients. Yeah, doesn't sound like many, and it isn't many. But from a scanning perspective, just to give you a sort of flavour of the cost. So this is all funded by the Rita Lila Weston Trust. So the grants for 1.2 million for the 32 patients. So you can understand trying to roll this out to large numbers isn't possible. But it's the proof of principle, because if we can show that, then actually the FMT intervention is much cheaper. Yeah. So the tools that we're going to use for this, as I said, we're going to do a very fancy PET MR scanner. So there are these new sort of scanners. Sort of UCL is UCL/UCLH has a nice sort of shiny PET combined with an MRI scanner, which is really important. I do something called transcranial magnetic stimulation. Sounds bad, yeah, but you can stimulate people's cortex. So all it is, if anybody remembers their physics, yeah, all it is a magnet that sits over somebody's cortex. The magnet collapses, yeah, or the magnetic field collapses, sorry, and it induces a current, and you can get your thumb to twitch. Yeah, I mean, I do this. I'm just gonna, without sounding too creepy, you can do this to yourself, yeah. So you can get your sort of hand to twitch. It's not painful at all. It's just a slight click, but you can get a feel of the entire sort of motor system. The interesting thing is you can also upregulate areas, so I can make people learn faster by upregulating an area. You can make them learn a little bit slower as well by downregulating an area. Yeah, but that gives us an idea of the motor cortex, and it gives us an idea of what's going on the other side, without needing to slice the brain up. And then finally, the big question is, okay, so which poop do you use? Yeah. Now, as you guys, I mean, this is an area that I'm very naive in, and so it's an area that I'm sort of learning about FMT. Now, from my understanding, home brewing was a thing. Thankfully, now you can imagine as a neurologist, yeah, the thought of directly transplanting sort of microbiome would not go down well with my colleagues. Yeah, it probably won't go down well with the patients. Thankfully, there's a non-profit organization which was set up by some folks at Harvard, ex-Harvard and MIT folks, called Open Biome. They produce tablets. Yay. Yeah. Honestly, such a sense of relief when I sort of realised that that we can interfere with the microbiome by asking the person to swallow 25 or 30 sort of vitamin-sized tablets, which is great. The key, from my understanding, is it's not just a matter of packaging things in a tablet. Once again, this is something that is outside of my area, but about how to deliver that effectively so the microbiome sort of takes on. But they appear to be very good at doing that. So that is a big relief to me. So this is, I mean, this is all theoretical, and I keep sort of stressing that, because the thing about science is that I can't remember who has this quote, but there's a quote about the great thing. I mean, you can have a beautiful hypothesis, but ultimately it can be spoiled by one simple fact, that it just doesn't work. Yeah. And so we need to be, although there's lots of excitement, and I'm truly very, very excited by this, and I really do think that there is something there. It is very theoretical at the moment. It could be, and motor neuron disease is useful in the sense that because it's topographically specific, I know where in the brain the hand area is. This could open up the pathway to other sort of neurodegenerative diseases as well. So Alzheimer's disease, and we sort of know this. I mean, we know this clinically because we know that people, say with delirium and other diseases, we know that their cognition sort of fluctuates and changes with their particular sort of illnesses. I like the idea of being able to use a mouse model, not because I work with mice, but it's because it moves us from association to a causation. And one of the things that we'll be looking at doing is that we can put, who'd have thought, you can put a mouse in a PET scanner. Yeah, it's a small PET scanner. Yeah, it isn't as cute as you'd imagine. My mental picture is much cuter than the reality. But the nice thing is that what we potentially can do is we can use the same ligand, i.e. the same thing that makes the microglia glow. We can use the same ligand, we can use the same actual microbiome, because we can get a patient microbiome, pop it into the mouse. And so the only thing that's different is the mouse is actually the model. But with the mouse, obviously, we can explore that at a histological level. As I said, there are many, many unknowns to all of this, particularly to do with a transplant. From a target perspective, there are massive unknowns. We don't know what happens in the motor neuron disease patients. We don't know how normal their microbiome is, so we don't know what we're replacing, but we're going to try to normalize it with whatever American poop is normal for. Just on one of those points, when I was speaking to the Open Biome folks, because I had lots of questions about this, about what does it take and how much screening that goes on. And actually it turns out that actually only about 1 or 2% of all the people who apply actually make it through. Basically because they screen for all sorts of different things, not just obviously infections, but to do with the habits, antibiotic use, family history, all sorts of things, which is actually, I think, very, very reassuring. But still, there are sort of many, many unknowns with that. As I say, I could be standing here in a couple of years saying, you know what, it's a great theory, but hey, it doesn't work, right? Given motor neuron disease and all the neurodegenerative disorders, they are awful, truly awful. So in that context, I'd prefer to give it a go, yeah, and see whether it works. And if it doesn't, then it doesn't. But rather than simply saying, you know what, it isn't going to work and not try. So thank you.